It's an honor to be here amongst those who studied loading to in the extents and now practicing unloading as a form of therapy in cardiovascular medicine. So I'm talking a bit about mechanical left ventricular unloading within acute decompensated heart failure. Again, maybe the language is not anymore what it used to be, or maybe Dr. Buscourt is kind of hitting on me, but this is the nomenclature that I used for this trial. It's the Unload HF trial. These are my disclosures. Well, first of all, and then again, sorry for the language. Maybe this is not what you want to read at this moment, but we're all aware that the patients that we see now in the cardiac care unit are more and more patients with acute heart failure. And most of them represent patients that come in with acute decompensated heart failure, which is based merely on the fact that these patients have acute and chronic heart failure. We are all aware of the fact that these patients have kind of decongestion, have increased pressures, have dilated ventricles, and this is all because of water and salt retention. When these patients put on diuretics, most of them will go home after 3 days in the US, I was just told, because it's necessary here in the US. But in the Netherlands, it's more and more a bit longer, like a day or 5. But during these days, these patients can have signs of worsening heart failure. That means that the symptoms, they may not reside, they may get even worse, and that's a reason for escalation therapy, at least in Europe. Patients that do worst are the patients that have acute decompensated heart failure and signs of hypoperfusion, which you can see in a very recent study published in 2022. These are patients that presented with congestion and hypoperfusion in different degrees, and you can see that the amount of congestion as well as the amount of hypoperfusion determines whether these patients have a good prognosis or a bad outcome as of mortality or in-hospital prolongation of their hospital stay. So, and especially hypoperfusion in these patients is very critical. And actually hypoperfusion is kind of a shock, what we're talking about. Something about the pathophysiology, we're all aware of this. Patients who have diminished left ventricular function, they have activation of sympathetic nervous system as well as renin-angiotensin-aldosterone system, and this in its turn will increase the neurohumeral axis that has a detrimental effect on kidney function, increasing central venous pressure, but also wedge pressures. And again, this is not only on the kidneys, but this is a more systemic disease in which also other organs are involved, like the liver and the lungs. So you have kind of a multi-system disorder when this kind of congestion prevails. Again, a bit of pressure volume loops. Getting here at Acute, I thought I had to put in one, at least. So I took this one because this is a very nice scheme of how the history or the developments within cardiogenic shock, whether it's related to myocardial infarction or related to heart failure, shows you that there is a direct decrease rightward and downward movement of the pressure volume loop. And then by activation of the neurohormonal system, you will see an increase in pressures as well as in volumes. And that's something that triggers kind of remodeling, and we end up with dilated ventricles with higher pressures. And that's also the point that thinking of unloading, these patients may be well unloaded, having noticed that these are large ventricles with high pressures. And of course, the Impella is well known for its unloading effect. You can see a scheme here in which you can see a decrease in pressures as well as in volumes. And that will have two effects. First of all, unloading, but also the Impella increases cardiac output, thereby kind of promoting systemic decongestion by optimizing organ perfusion. I won't go into detail on this slide. Just wanted to show you, you have seen these hemodynamic profiles already by Dr. Boskort, that the hemodynamic profiles of patients with acute decompensated heart failure are normally warm-wet, but when they have kind of signs of hypoperfusion, they will go into cold and wet. So it was discussed already which patient, if you want to tackle these patients in the trial, which one do you want to include? Where in the severity of shock will you include them? How do you include them? Is there one uniform kind of way that you tackle the patient that you want? Is it early enough to tackle them? Well, there are some profiles here. It's already been shown also, but these do not adhere to the patient category that I really wanted to select. Also, the shock stages that you can see here, they're kind of rough, and they're evaluated more in acute myocardial infarction, and we're talking here about heart failure. So, but luckily, the SKY criteria came into play like 2 years ago, and there is a nice increase in shock severity described with hemodynamic, biochemical, and clinical parameters. And that nicely addresses the stage which patients are in at the time of shock. And this also gives you information on what therapies you can use, and also on the prognosis and on the effect of your interventions. So the SKY criteria that were evaluated in several cohorts of cardiogenic shock, but also in heart failure shock, proved to have an association with mortality. The higher the SKY shock stage, the higher the mortality was. So these are the latest versions of the SKY criteria. And within these SKY criteria, you can also see an additional refinement of the hemodynamic consequences and the consequences of hyperperfusion, which each have a different rate of a range of parameters within each stage. And in this way, you can absolutely define your patient that you want to include or exclude from your trial to get a very nice population that you study in your randomized controlled trial. One of the things also that was intriguing to me is what you see on the right side. That is that patients that present in SKY shock B or C, there is 9 out of 10 patients that present in B that will go into C. And 7 out of 10 patients out of C will go into D. So this means that you also have a time course of the patients during their hospitalization. So you already know how your patient will develop or will need escalation within their hospitalization. And you also can see the time that the patient spends there. So if you're in B, you escalate only after 50 hours, then you will escalate to C. And when you're in C, especially for heart failure, it takes you 120 hours. So this gives you an insight that you have a time limit in which you can actually intervene, knowing that the patient will derange. So that's one of the other things, that maybe we act too late. If we intervene too late, especially in cardiogenic shock, we know that the problem that we have initially, which is a hemodynamic problem, will kind of become more an hematometabolic derangement. And that might be one of the reasons why there is no efficacy shown yet from mechanical support in cardiogenic shock at this moment. So, talking about the treatment of these patients, of course, everybody's getting inotropes, at least that's what I think. The indication in the US is somewhat different as in the Netherlands or in Europe. We have a class 2B, whereas you have a class 1, and that's probably because there is no data there. Inotropes don't work. There is no randomized controlled trial that shows you that inotropes have a positive effect on survival. So that also reflects in our guidelines. It's a 2B, whereas mechanical circulatory support has a 2A in our Europe. And it has the same indication in the US. So one might think, and one might trigger whether or not we should kind of start with mechanical support in patients that show hypoperfusion or shock, instead of starting with inotropes. Maybe a bit silly, but there is some data out there. Maybe you you know this study. This is from a colleague from Rotterdam, Den Uyl, and he studied in patients with low output cardiac failure on the ICU. He started and he randomized between inotropes and hemodynamic support. This hemodynamic support was a balloon pump, so it's not that much. But what you can see, he took as an endpoint the mixed venous oxygenation, and you see in the blue line the effect of IBP, and in the red line the effect of inotropes. And what you see is that there is a massive increase of oxygenation when using the IBP, whereas in the inotropes arm there is only less. And also looking at the pressures into the patients, you see that by the right heart cath, that the wedge pressures remained kind of equal within the inotrope group, whereas in the IBP group they dramatically decreased. So all these things led to the following hypothesis that we are going to test, and that is that a primary, so a direct introduction of an impella patient, impella in patients that have acute decompensated heart failure with evidence of hyperperfusion, according to the SKY stages, so B or C, will have a superior outcome as compared to a standard treatment with inotropes, with respect to a combined clinical endpoint that consists of all-cause mortality, and this one is very interesting to me, worsening heart failure. And we specifically addressed it as worsening heart failure, and this means actually that you can, following the steps of the SKY stages, and when patients have the hemodynamics and the biochemistry of D or E, they have their own endpoint. And of course, it's hypothesized that in the impella group, this will happen to a lesser extent than in the inotrope group. Also, all other organ failure, like renal failure and need for renal replacement, or pulmonary failure, need for intubation, and also on the long-term rehospitalization is thought to be less in the impella arm. We have key secondary endpoints that consists of right heart cath measurements. It's the wedge plus the right arterial pressure. This is also from the ESCAPE study. And you see that when it's less than 30, it prognosticates to less deaths compared to higher pressures. So the study design is like, it's a randomized controlled open label trial. It's multi-center, 2-arm. The intervention is either impella plus or minus inotropes, because that's standard of therapy, or inotropes alone. The design is a 2-stage. It's like the design of Benedict. First, we do a certain assumption. We include 2 times 77 patients. We will see where it ends after having educated the results of the first 120 patients. And then under an assumption that the conditional power is between 80 and 40%, we increase the number of patients to 2 times 228. Of course, we do an intention to treat, but also a per protocol analysis. And this is the inclusion criteria. As stated, we need to have acute decompensated heart failure, and this is not MI related, non-coronary syndrome related, acute decompensated heart failure with evidence of a reduced ejection fraction of less than 35%. These patients need to have signs and symptoms that are persistent of congestion. And then we introduce the SKY criteria, as you can see below. There are 2 additional points there. It's B and D, and that's from the paper of Jenser, and he reflected that hypotension was also related to the increase in creatinine or the diuresis, and we incorporate those as well. So those are the criteria that patients can come in and will be included in this way. Then we have the exclusion criteria, as stated, acute coronary syndrome, and also patients who are too sick, who are further in their cardiogenic shock stage, will be excluded. So it's just a very selective patients that we think benefit from early intervention with a CP in this patient category. So we will randomize. This is the scheme. It's either Impella plus or minus inotropes versus inotropes alone. And every patient will get a pulmonary artery catheter to see what the pressures will do. And this is kind of the scheme that the patients after randomizations will adhere to. First of all, if you randomize to the Impella arm, you will rush to the cath lab. A pulmonary catheter will be inserted as well as the Impella. We have a delay of maximum 6 hours. Sometimes it's even longer. Because of operational uses, then it may be 12 hours. But within those hours, the Impella needs to be within the patient. During that time, inotropes are allowed, but once the Impella is in, it's kind of, you should progressively wean them. Maybe you will continue them, that's also fine, but please try to wean them. At least we will tell that to our participating sites. And then we need active support for at least 48 hours. So the key secondary endpoint is also at 48 hours. Time 0 is start of inotropes or Impella. At 48 hours, we have the key secondary endpoint, meaning the right heart cath. And afterwards, it's stimulated to keep the Impella in for 5 days because we're allowed to. If it's not necessary, and of course we also have weaning algorithms, etc., based on saturation, pressures, etc., but then you may wean and get it out. In the inotropes arm, it's fairly easy. When they're randomized, you can start inotropes, and then we have the same endpoints. Then something about the worsening heart failure, and I think this is elementary for the trial. Of course, people will get sicker, probably. And I don't want to have crossover in the trial. I think crossover kills the trial. So we wanted to kind of get a crossover become a clinical endpoint. So if a patient deteriorates in your inotrope arm, that means showing the hemodynamics and biochemistry of stage D, of course you're allowed to put extra inotropes, but that will give you an endpoint. Of course you are allowed to put in an Impella, but that will get you your endpoint. So in this way, we will keep the endpoint, the crossover percentage actually at the level of 0. But we will have an endpoint by terms of worsening heart failure. In the Impella arm, inotropes are allowed, and you're kind of addressed to progressively wean them. If you stay on that inotrope, we don't count it as sign of worsening heart failure because you started with it. When you add another inotrope, of course, then you will have your endpoint. So only then, that's a sign of worsening heart failure. And maybe something different as a part to kind of the way vasoactives are perceived. We don't think that noradrenaline is a sign of worsening heart failure per se. How often do we just need some tension or whatever, or during the introduction? You give some noradrenaline, but it's not worsening heart failure. So noradrenaline is allowed within the trial and is not seen as a vasoactive that attributes to the SKY criteria. Of course, after the trial, patients get weaned. They will put on guideline-directed medical therapy, and we have the endpoint, primary endpoint at 60 days. At 30 days, there's also we're also going to score the endpoints, and at 1 year, we do a telephone call and see whether the endpoints are there, yes or no. So that actually is the trial. So to summarize, acute decompensated heart failure is very common, serious condition. It's congestion, diminished cardiac output, high filling pressures, and patients that have evidence of hypoperfusion are really sick and need to have attention. We kind of see those patients in cardiogenic shock, having cardiogenic shock either B or C, and we will unload them with the Impella as a very attractive alternative in these patients category. And we're kind of testing the hypothesis that the mechanical unloading is actually better than inotropes, but also we're testing the timing of the intervention. That means that we directly go to the impeller instead of that we introduce the impeller only after inotropes fail. Thank you.